My name's Kevin Gibbons, and I will be presenting. I'm the co-founder and executive director um, of Health Access Connect, and Costa will be presenting a little bit with me. You want to say hi real quick, Costa, and introduce yourself? Great. And today we'll talk a little bit about I'll talk a little bit about what the HAC does, and then Costa and I will talk about why we love this work, um, and then I'll talk some about how 2020 has been for HAC, and then look forward to what next year is going to be like for us. So what does HAC do? Um, our mission is to link remote communities to healthcare. That verb of to link is really important to us because as much as possible, we really try to use resources that are already on the ground in these remote Ugandan communities where we work. Um, so that because the community has resources, the government health system has resources, and our role as HAC is to sort of bring them together and make sure that those underserved communities can get access to healthcare. Um, we started working in the Lake Victoria region of Uganda, which has very serious sort of transportation and logistical challenges, long distances in between health facilities and communities, uh, and high rates of HIV. Um, and so in the first communities that we were going to, um, and where we saw the problem was that communities would say, well, my neighbor had died of HIV a few months ago, and that other one died a few weeks ago. And that still happens, even though antiretroviral treatment and a lot of other health services are free at government health facilities just a few kilometers away. Um, and so that's what we really developed the organization around. How can we get those services that are already available to really save lives, improve people's lives? The way we do this is through our Metacycles program, which is monthly or bi-monthly, one-day integrated care outreach clinics in remote areas. That's a mouthful. Basically, we don't, our model is don't wait for the patients to reach the health facility. Bring the health facility to the patients in these remote areas. And it looks a lot like um, this motorcycle right here. Put a health worker and her supplies, 2 to 4 health workers. So if you use this motorcycle, you use 2 trips, but in some cases use a car or a boat, uh, and put those on the motorcycle, deliver them to an area, and they set up shop in a church or a mosque or a school or another public building and sort of serve patients in that area. They need a means of transportation, someone to mobilize patients on the ground, sort of tell everyone in the community, hey, they're giving out immunizations, they're, doing uh, antenatal checkups for women, et cetera, et cetera. And then you need the money to cover the sort of basic transportation costs. And that's one of the most important things that we do is that each outreach clinic that serves between 40 to 50 patients on average costs about 20 to $30. That's an amazing, can you imagine $20, $30 to serve 50 people who live in a remote area? Um, and those costs are basically a small travel allowance for each health worker who leaves the health facility, the equivalent of having a lunch and sort of um, for that day, and then a small amount for fuel for the motorcycle or car or boat, and then a small amount for the organizer, usually a community health worker or local leader. And so that adds up to that amount. And so every time those happen every month, you have to cover those costs. And we start with a radical premise that these communities can do that, right? That they do have the resources and can provide that. And so communities pool their wealth. Each patient who attends provides the equivalent of about 55 US cents. That's gathered by a woman like this who would be sitting on the outside and would gather that money and then use that to sort of cover all the costs. And so you have this sort of financially sustainable, sort of community-led model of sort of making sure that you address that need and that gap. And that's, that's the essentials of what we do. We try to go around spreading this model and sort of addressing the gaps in healthcare in remote regions of Uganda using this model and improving the way that we roll it out. And so our vision as an organization is to set the standard for how to bring sustainable, equitable health services to remote, marginalized communities. And that's how we do it. Very practical, shareable, scalable way of improving service provision. Um, and so Costa and I are going to talk about why we love this work. Um, to to sort of get, aside from the model, what is it that drives us to do this work? Because it can be difficult work to do. Um, if you'll hear me, I'll read this quote. In the past years, this is from a woman who lives in one of the remote communities where we serve. Health issues were in a sorry state. Some people could even fail to get health services. People could die in big numbers. They could fear to go for drugs because the health centers were very far. But when they got an opportunity getting the drugs nearer from here, they were very much pleased. Indeed, we have been getting very many who come for health services. In regards to transport, our nearest health facility is Mulabana Health Center, where we used to go on foot. Ever since Health Access Connect came in, we get better health services. They bring for us the drugs, and here she's mostly talking about antiretroviral treatment, and we go back home when we are contented. Uh, I feel I have peace ever since Health Access Connect came in, though I'm a single mother. Even the members of the community like this system so much. What I really love about this quote is that it highlights how important the logistical challenges of accessing healthcare are. The gravity of the kind of areas that we work in, of the health needs of people, and also how much the programs that we do, how much impact that they can have in people's lives. Costa, when you read this quote, what do you see? Thanks, Costa. That means a lot coming from you. Um, so the next quote is from a health worker um, you can see on the other side of the screen there. Uh, at first, I was opposing the Health Access Connect outreach clinics. I was like, people will not be able to raise that money. People would not be interested in it. I was among the people who were opposing it at first, knowing that people would not pay that money willingly. And just to interrupt here, uh, what she's talking about is mostly when nonprofits or NGOs or other government programs come in, they're sort of working to provide things 100% for free, and which is great, but the problem with that is they sort of run out. The funding runs out, and so service there's a problem of sort of not getting continuity of services, and also it ends up leading to the expectation that everything will be provided for free in the community. So what HAC is doing is different in that sense, in that it's giving ownership and also sort of responsibility to communities and the health workers to sort of make sure that service provision sort of continues to happen. So I'll continue. But out of my surprise, the people picked interest in it. Now I can tell you that before we used to carry out normal outreaches, we could not associate much with the people, but because of Health Access Connect, I think we are developing a relationship that is now becoming bigger. We interact more with the clients compared to how it was before, and they are thrilled with us. They are very thrilled with us. What I love about this is one, it's come from a real skeptic. I remember going to the initial meetings with this health worker, and she was like, "All right, we'll try it out. This isn't going to go well." Um, and it shows that, more than the services itself, what we're doing kind of improves the relationship between the health workers and their patients and their ability to sort of serve those underserved patients. How about you, Costa? What do you see in this quote? Thanks, Costa. Um, so let's talk a little bit about 2020. How has it been for us? Just a little background. COVID in Uganda, the number of confirmed cases has been pretty low. Partly that's been due to, especially early on, there were very strict travel and gathering restrictions. Um, and so it's been really managed well. The government of Uganda has really been responding to the recommendation of public health professionals. But it also reflects um, problems in testing, gaps in data, like exist around the world, but are probably um, more influential, a bigger deal in Uganda. There have been, relatively few confirmed cases and very strict restrictions. And at some point in there were no motorcycle taxis. And so much of what we do depends on motorcycle taxis, public transportation, which was shut down for 6 to 8 weeks. Um, in terms of access to healthcare, there's a lot of fear of going to the health facilities because of, you can't really sort of keep all the patients separate in the same way that you can um, in, richer countries. Um, and that limits people from accessing that, and the lack of resources really limits people from accessing healthcare. And one of the dominant things we see are that, there's more unemployment. The economy was sort of came to a halt early on with the heavy restrictions, but now it's still sort of there's still more requests for food aid. And that really has to do with people not necessarily having as much wealth or a social safety net to fall back on. So margins are just tighter in Uganda, and we're seeing that on the ground. Um, some of the major questions that we had as HAC were, can we continue to provide services? Um, is it possible in this area of the different public health restrictions? Are we going to lose the progress of what we've built over the last 5 years, um, doing what we're doing? Having this sustainable model now, and where do we fit in a world under COVID and beyond? Those were questions we were talking about very seriously for months, um, and we were trying to understand what we could do. Should we just be focusing on COVID? Should we not? And so, but we decided, well, let's keep, there's still gaps in primary healthcare. We did research on the ground, and there were still, we saw, and what you see around the globe, that um, people are having trouble accessing primary healthcare services like antiretroviral treatment, immunizations, family planning, and yet that's what we do. Those are our core competencies, our bread and butter, and so we should keep doing that. Uh, and so these are our numbers of what we've accomplished to date. The sort of darker magenta line is this year to date, up through October. Um, and then as compared to the sort of lighter pink line, that was the previous year. Um, and numbers are down. The number of patients served is down. The number of outreach clinics that we conducted was down to the previous year. And much of that has to do with, if you see March, April, May, um, numbers were way down as things were heavily restricted. But you see, numbers coming up in June, July, and August as we push to have more outreach clinics restarting. Governments and communities were coming to us and saying, we need to get these things restarted and start in areas where we hadn't been before. We've expanded to new communities. And also in that time, in June and July, we provided some free outreach services because of the scale of the need on the ground. And that helped us kind of restart the outreaches and provide services at a time when um, people were really needed it. And so you'll see that actually the numbers of patients attending really climbed during that time and have stayed higher than they were in the previous years. Um, so we're really proud of this page, as a business, as a nonprofit, this is what we really try to do, make outreaches happen, make sure patients are attending. And it's been a difficult year, but we've been able to operate at a time when outreach activities across the world have declined or totally stopped in a lot of areas. And it's been led by Costa Rica, have been able to address that. Another program we had was for family planning, to improve access to family planning. Um, One of the issues is sort of a lack of training or prioritization by health workers, don't know how to administer certain methods, and hadn't really sort of done a lot of practical training, and um, lack of access to particular commodities, some methods, birth control pills, IUDs, what have you, would run out at the health facility. And so we were making sure that there were additional methods there. And so when somebody came, especially women came to sort of access those methods, they were there and accessible. Our target was to provide 1,680 couple years of protection, CYPs. And that's a measure of sort of protection um, of under family planning. And at some point in the year, um, about midway through the year, we thought we may not meet half of that. It's a real struggle to get anything done. But we worked really hard. Our staff member Winfred Nakawesi, who works on the project, is an amazing leader, and we actually, more than doubled what we set out to do. Um, and a lot of that had to do with providing some family planning specific outreaches, working with the health workers that we had been training to figure out how they could provide those services, meeting patients where they were, um, and it actually provided a good model for how we can be flexible and focus on the needs of the health workers and patients that we work with to sort of make sure that that was possible. So this is another number that we're really proud of over this time in 2020. Um, Additional accomplishments, we were part of we distributed 1,000 mosquito nets to people in remote areas, especially the most vulnerable populations. Early on, when there were real emergencies, we distributed some PPE and grants to local governments to help them respond. at a time when there weren't masks. People didn't know what they needed. There were no hand washing stations at some health facilities and some of the outreaches. Um, and so we worked really hard to sort of make sure that those were available to people. Um, and then over time, since we couldn't expand, we've been focusing on quality of service, making sure that things keep going, that there's social distancing guidelines in place, everybody's safe. And that continues to this day. That focus has been, now that whether or not we can expand may be up in the air for the next year, a few months or a year. Um, we're going to continue to make sure that those services are of high quality. And then lastly, continue to expand because in this time, we are back up to and maybe a little bit above of where we were before COVID started, and we're in a new district and have started a new sites. So expansion continues to be a kind of way that we see ourselves moving forward. Since August of 2015, we've conducted, over 627 outreach clinics, served over 28,000 patients, and an average of 44.6 patients per outreach. And this has really been on a shoestring budget. Um, so we're really proud of that, and it also, gives you a window into how we see our operations and what we're really trying to do, and that's bring services as close to people as we can, and and on a regular basis. Um, and I want to talk about some of the things we're really excited about in the year to come. Um, our vision for Health Access Connect is, continue to build a network of remote villages that are um, uh, hosting services, hosting outreaches on a monthly or bi-monthly basis. Um, and then use strategic partnerships to expand, improve, integrate, or add more health services into those outreaches, and then have a global impact, document and share our model with other service providers and governments, and take what we've learned and sort of help it to serve, you know, help it to expand access to health services and improve the lives of millions of people. Um, and these three I've been showing this slide for about 2 or 3 years now, and these three bullet points are the things we're most excited about for the year to come, because our vision for what we're doing next really um, has stayed constant. Um, we're going to continue to expand, use those partnerships, and have global impact, and that's what I want to talk about. Um, this map, which we've gotten access to recently, um, this is the number of these are numbers of people with HIV in the pink and red pixels on the map. Numbers of people with HIV who live over 5 kilometers from the nearest health facility. Um, and so this actually is a really great detailed map of this is where HAC needs to be. These are where the underserved populations are that we can serve, and where we need to go. Uh, and so that's where we need to be. Right now, we are in about 49 communities in the South Central region, bordering Lake Victoria there. And so we'll continue to expand to serve the areas nearby and continue to grow and address those areas. And these pixels are about people living with HIV, um, but that also highlights where in the country, aside from just HIV, there are also gaps in access to kind of general health, other primary healthcare services. Um, we have built a partnership with the Africa Resource Center. They're a Bill and Melinda Gates Foundation and USAID funded, among others, uh, organization that focuses on supply chains. Everybody in the world, we've become sort of supply chain experts, or at least amateurs, over the last year. And the people who work for Africa Resource Center have experience in the private sector with Coca-Cola, beverage distributors, pharmaceutical companies, and are taking that private sector experience and working with ministries of health all across Africa to improve service provision, improve access to healthcare in those countries. In Uganda, they've been tasked with helping the Ministry of Health improve service delivery to people living with HIV. And what the Africa Resource Center and so we connected. They've met all of our staff. They attended some of our outreaches and some of our workshops and meetings. And they've gone to the Ministry of Health in Uganda, National Ministry of Health, and said, this map HAC's model or some version of it needs to cover all the communities highlighted in this map. Um, and that's one of the primary ways that you can improve health services in the country and reach those underserved populations. Uh, and so over the next year, Costa, uh, our colleague Bridget, and I will be working with service providers across the country to sort of make a playbook of how HAC, how we do what we do, and sort of teach others how to do that so that they can implement it in their areas. Um, I'm so excited for the year or 2 or 3 years to come of sort of rolling this out and sort of taking what we've learned and teaching other people how to do it. So we can go from serving tens of thousands of patients to reach hundreds of, if not millions of patients in the next couple of years. Um, so we'll be sort of working on that more. Um, and but on top of that, we're still implementing, still growing as an organization, doing that technical advising part, uh, and implementing on the ground and reaching those additional communities. So you should rightly be asking, well, this sounds great. Well, what can I do? That's a great question. That technical advising work is supported by ARC and a grant that we're getting from USAID, but we still depend on donor funding to support the outreach clinics that we conduct and the implementation work, the thing that makes us so useful to the world and so useful in expanding access to healthcare. So we depend on those donations. So far we haven't received, large grants to do that work, and it's individuals like you who have helped us to make that possible. So I encourage you to donate at healthaccessconnect.org/donate or on our Facebook page. We make a commitment to take the investment of donors and be stewards uh, of that investment to improve access to healthcare in the most marginalized, underserved communities. So I hope on Giving Tuesday and beyond that you consider HAC in your giving.